Hello friends, I am Dr. Ghulam Nabi Memon. I will discuss ultrasound guided radial nerve block today. The objectives of my presentation are to discuss the relevant anatomy of radial nerve, preoperative assessment and preparation of the patient, indications and contraindications of radial nerve block, complications and side effects of radial nerve block, prerequisite of radial nerve block, equipments and logistics required for the block, ultrasound setting. After that, we will discuss sonoanatomy of the radial nerve, how to make position of radial nerve block, conduct of radial nerve block, what will be intraoperative care and what will be postoperative care and clinical tips. Relevant anatomy. In relevant anatomy, we will discuss radial nerve in the axilla and in the arm, radial nerve in the forearm and radial nerve in the hand. In the axilla and arm, radial nerve arises as last branch of the brachial plexus posterior cord, or we can say it is continuation of the posterior cord of brachial plexus. This nerve arises at the level of the third part of the axillary artery, behind the third part of the axillary artery. Radial nerve contains all 5 nerve roots of brachial plexus, which are C5, 6, 7, 8 and T1. Radial nerve arises behind the third part of the axillary artery and remains behind the brachial artery because the axillary artery continues as brachial artery. At the same position means posterior to the axillary artery and then posterior to the brachial artery, and on ultrasound we can see it as a 6 o'clock position. Then it enters the arm at lower border of teres major muscle and passes through a triangle and enters the posterior compartment of the arm. In posterior compartment, it passes between long and medial head of tricep. It winds in radial groove of the humerus, accompanied by the profunda brachii artery. Then comes in the anterior compartment by piercing the lateral intramuscular septum near lateral epicondyle. It innervates all the muscles of the posterior compartment of arm and forearm, that all the extents of arm and forearm. This is the diagram showing the brachial plexus around the axillary or brachial artery. We can see the posterior cord behind axillary artery and then brachial artery, and the nerve behind it is posterior cord and then it is continuous as the radial nerve. Radial nerve gives 3 branches in the upper arm, then runs down between medial and lateral head of triceps. It supplies muscular branches to long head of tricep, medial head of tricep, and a sensory cutaneous innervation of posterior cutaneous nerve of arm. Radial nerve gives again 3 motor branches in the lower arm, which supply to lateral head of tricep, a motor branch, lateral cutaneous nerve of arm, which is sensory, and posterior cutaneous nerve of forearm, which is again sensory. This is a diagram showing 3 branches of the radial nerve when it enters the upper arm. Radial nerve course and branches in front of the elbow. Radial nerve, after traveling in the radial groove in humerus, accompanied by profunda brachii artery, comes in the anterior compartment passing through the loteng fascia, which is also called lateral intermuscular septum, which separates the posterior and anterior compartment of the arm. Here it is located between the brachialis and brachioradialis muscle. It then courses anterior to the lateral epicondyle or in front of the anterior epicondyle and divides in its superficial and deep branches in the forearm. In front of elbow, it gives muscular branches to extensor carpi radialis brevis, extensor carpi radialis longus, and brachioradialis muscle. Radial nerve in the forearm. Radial nerve enters the forearms and divides into superficial and deep branches. Superficial branch of radial nerve in the forearm, which is purely sensory. It lies deep to the brachioradialis muscle. It courses lateral to the radial artery towards wrist. Becomes superficial at 9 cm from stellate process of radius, penetrating fascia between brachioradialis, extensor carpi radialis longus, and reaches to anatomical synapse. It is crossed by the cephalic vein above the wrist. It then enters hand and gives dorsal cutaneous branches. It receives sensation from dorsal and medial skin of the hand, that is from dorsum of the thumb, index finger, the middle and lateral half of the dorsum of the ring finger, leaving nail area for median nerve. This is a diagram showing superficial branch of the radial nerve which we can see on the lateral side of the arm and runs towards the anatomical nerve box. Initially it is below the brachioradialis muscle and then it comes superficial. This is the diagram showing the sensory innervation of the dorsum of the hand by the radial nerve. We can see the dorsum of the thumb, dorsum of the index, dorsum of the middle finger and lateral half of the ring finger, leaving the nail bed area for median nerve. Deep branch of the radial nerve in the forearm. Deep branch passes underneath arcade of Roche between two heads of the supinator muscle in radial tunnel and named as posterior interosseous nerve and enters the posterior compartment of the forearm. Deep branch supplies 7 deep muscles of the forearm and reaches the interosseous membrane and moves towards the wrist, where it supplies fiber to the dorsal capsule of the wrist and terminates. The muscles supplied by the deep branch of the radial nerve are superficial muscle, extensor carpi ulnaris, extensor digiti minimi, extensor digitorum communis. Deep muscles are abductor pollicis longus, extensor pollicis longus, extensor indicis brevis, and extensor pollicis brevis. The diagram showing deep branch of radial nerve. It is posteriorly placed. It comes from the anterior of the lateral epicondyle and through the supinator muscle it becomes posterior. The anatomy of radial nerve showing all the distribution of sensory and motor branches. A diagram of sensory innervation of full arm by radial nerve. Preoperative assessment and preparation. In preoperative assessment and preparation, we take history, do physical general examination, we do laboratory investigation, and we do risk assessment and grading of the patient. We optimize the patient if there are comorbids and prepare the patient for ultrasound, guided nerve block and surgery. We take consent from the patient, we give the patient NPO and we do the side marking. Indication of the radial nerve block. Indication include repair of the laceration in the territory of the radial nerve, excision of the skin lesion, incision drainage, foreign body removal, finger amputation in the territory of the radial nerve. Metacarpal and phalangeal fracture and dislocation can be made pain-free by this block. Rescue analgesia can be given for failed inadequate regional block. For example, if we are giving supraclavicular or axillary block for hand surgery, and if we find the block inadequate or fail, we can augment the block with radial nerve block. We can give supplemental to the median nerve block. Radial tunnel syndrome surgery can be done under radial nerve block. Radial nerve block can be used for post-operative pain following arthrolysis and tenolysis. Radial nerve block can be given for analgesia for burns to the hand. It can be used for creation of AV fistula in combination with musculocutaneous nerve. Contraindication. Contraindication of radial nerve block are patient refusal and non-cooperative patient. Local infection and the sepsis at the site of injection. Allergy to the drug. Neuropathy is a relative contraindication. Complication and side effect of the radial nerve block. Radial nerve block may be failed or it may be partially blocked. We can introduce infection through the puncture and it needs a sterile technique. Injection can be made intraneural, which is a rare possibility, but it can occur. Nerve injury including neuropraxia and neurolysis can occur. We can inject intravascular compartment, artery or in the vein. And because in mid-arm radial nerve block, there is profunda brachii accompanying artery. And in the antecubital fossa block, in the upper arm, recurrent brachial artery is accompanying the radial nerve. So it is a possibility. Bleeding at the puncture site, if we puncture the artery, it can cause bleeding. If the bleeding occurs, a intramuscular hematoma can develop. Local anesthetic systemic toxicity is a possibility if we exceed the dose or we use high volumes. Allergic reaction to any local anesthetic can occur. Reflex sympathetic dystrophy can occur. Chronic regional pain syndrome. I remember one patient in which we operated on the lower limb 4, 5, 6 times for many reasons, for debridement and this patient developed CRPS, which was very severe condition. I remember one case. Prerequisite of ultrasound guided radial nerve block. We must use sterile technique to avoid infection. Bright light source is mandatory to visualize the structure. IV access 18 gauge working must be available. We use standard monitoring like general anesthesia. Resuscitation drug must be available, including lipid solution. We need a trained assistant, which is a blessing for anesthetists. General anesthesia facilities must be in hand in case of problems. We take consent and detailed briefing of the block, keep the patient NPO and do sign-in. Equipment and logistics required are ultrasound machine with a high-frequency linear array transducer 12 to 18 MHz, ultrasound probe cover, and ultrasound gel, sterile gel. We need insulated blunt bevel echogenic needle of 35 to 50 mm length, and in obese patient maybe 80 mm length. We need sterile gloves, we need sterile cleaning solution, 4 sterile cover to isolate the block area. We need 5 cc syringe with local anesthetic for puncture site analgesia. We need a pressure mirroring syringe with tubing. We need sedative analgesic, midazolam, fentanyl, and ketamine. And this area should have the facilities of general anesthesia in case we fail. Ultrasound setting. We always put ultrasound machine in front of our eyes. We use high frequency linear probe with frequency more than 14 MHz. We use in-plane technique. Out of plane technique may be used because this is an interfacial compartment block. We identify orientation of needle and probe. We keep the angle of the needle with probe at less than 30 degrees. Please view next slide for management of angle of probe and needle. Best views obtained when the needle is kept parallel to the probe. Needle length should be 35 to 50 mm in an average weight patient, but in obese we may need 80 mm length needle. Depth setting is 1 to 3 cm in 70 kg person according to the patient. This is a diagram showing the maneuvering of the ultrasound probe to visualize the areas, the relation of angle of needle with the probe. So you see there is a 65 angle in a routine manner, but if we press one side of the probe, we can bring this angle to 25. So needle is visualized best. Taking position for radial nerve block. This block is executed in an area designated for regional nerve block. All facilities must be available in this area. Elevate the bed up so we avoid bending of the operator. We keep the patient in supine position. Arm is abducted to convenient. Elbow kept around 50% extended. Hand kept on the abdomen. Operator can work from side of the patient. Routine pillow support is kept to relax the neck muscle. This is a diagram showing the position of the radial nerve block. This is the commonest place where we put the block. This is the lower end of the arm, proximal to the lateral epicondyle, where the nerve is very clearly visible as a hyperechoic structure and very superficial near to the skin. There is no accompanying artery or vessel, usually easy to perform. Sononotomy is essential before every conduct of the block because there is huge variation in normal anatomy. So we must do the sononotomy. Radial nerve can be blocked at different levels. At mid-humeral position in the middle 1/3 of the arm. The second position, which is commonly used, is at lower end of humerus, proximal to the lateral epicondyle. The third best position is in front of the elbow before it divides into two branches, superficial and deep. The superficial branch, which is sensory, can be blocked at lower end of forearm near the wrist. We prefer to block radial nerve above lateral epicondyle for reasons. Number 1, sensory and motor, both parts are blocked in the arm and in the hand. There are no accompanying blood vessels in this area. Radial nerve is superficial and easy to block. It becomes interfacial block here between the brachialis and brachioradialis muscle. This is a diagram showing radial nerve sononotomy in the lower humerus above the lateral epicondyle. You see the nerve is clearly visible in an interfacial plane between the brachioradialis and brachialis. And the humerus is also clearly visible. Conduct of the block. Sonogram is done before preparing and draping the block area. Sign and site marking is done in the preoperative holding area. Steroid preparation of the area done and area isolated with towels. We use puncture site analgesia. We can conduct block at different levels: mid-humeral, lower humeral, elbow, and at the wrist. In this presentation, we will give emphasis on the lower humeral radial block. This is a diagram showing mid-humeral radial nerve block. When the radial nerve is traveling in the radial groove, and this is accompanied by the profunda brachii artery, and there are chances of puncture of brachii artery, which is major vessel, and there could be hematoma, there could be intravascular, there could be loss of the drug, so we should take care of this. Radial nerve block at the lower humeral level. The patient is kept supine, the shoulder is semi-adduction and the internal rotation, with the elbow 50% flex and the hand rested on the patient abdomen. You can see clearly in the next slide. The operator should be standing or sitting on lateral side of the arm. We place the transducer in an in-plane approach on the radial groove of the posterior lateral humeral distally. We identify the radial nerve as a triangular hyperechoic structure coming off the humerus at this location. Place the needle tip in an in-plane view from lateral to medial until it enters the facial plane adjacent to the radial nerve between the brachioradialis and brachialis. Confirm that the tip is not in a vessel by negative pressure and inject local anesthetic solution of your choice. The third position at which we block the radial nerve is in the elbow at antecubital fossa. Radial nerve can be blocked at the elbow before the nerve divides into superficial and deep branches. On ultrasound, we can see eye sign, two eyes. We keep the patient supinate the arm to facilitate placement of the needle, with the operator standing on the cephalic side of the arm board. We place the transducer from the lateral side of the elbow. We identify the radial nerve between the brachioradialis and biceps muscle. We track it down and identify the nerve from above elbow when it is coming off the distal humerus, following it distally to the antecubital fossa, where it divides into superficial and deep branches. We inject local anesthetic solution before the bifurcation of the radial nerve to block the sensory and motor component. We place the needle tip in an in-plane view from lateral to medial until we enter the facial plane adjacent to the radial nerve. Avoid intravascular injection by negative aspiration. We inject the local anesthetic solution of choice and observe donut shape around the radial nerve. This is a diagram showing the recurrent radial artery accompanying the radial nerve. I am highlighting the radial artery in this diagram, which is accompanying the radial nerve. So we should take care of the puncture of this vessel when doing this block. This is the reason we prefer lower humeral block where there is no big artery accompanying the nerve. This is a diagram showing a radial nerve block in front of the antecubital fossa at the elbow. You can see the eye sign. Arrow is indicating two eyes, which is the two branches of the radial nerve. And we have to give block before the two eyes appear. The fourth position is near wrist, and we block the superficial branch of the radial nerve which supplies the skin of the hand. In this diagram, you can see this can be blocked at 9-10 centimeter above the wrist, where it becomes superficial. In this diagram, you can see the flattened radial nerve near the radial artery, or we can say lateral to the radial artery, between the bone and the radial artery. Intraoperative care. We brief all detail of the block to the patient before starting procedure. We apply full standard monitoring as far as general anesthesia throughout the procedure. We avoid hypothermia and use full body bear hugger. We test motor and sensory block before tourniquet and before the incision is made. Motor block is tested by finger movement, extension of the finger. We isolate the limb by full screen. Pseudoanalgesia can be given but better after incision for surgery. Pseudoanalgesia can mark signs of loss like metazolam. We monitor for the local anesthetic systemic toxicity, keeping in hand lipid emulsion in OR and also in recovery. Alternatively, close verbal communication maintained with patient. In case of inadequate block, get ready for converting the patient to general anesthesia. Post-op care. We shift the patient gently to the recovery area after finishing the surgery and dressing. We apply monitor same way in the recovery area. We monitor for the local anesthetic systemic toxicity. We protect the patient from injury with arm string. Inform the patient about approximate time of return of the sensation. We exchange cell phone contact to assist in case of problems or queries from the patient. Early mobility is possible with the radial nerve block. Early resumption of food and drink is possible with the radial nerve block. Early pain-free physiotherapy is possible with the radial nerve block. We prescribe analgesia IV or oral when block wears off. Clinical tips. We put ultrasound machine in front of our eyes. Sonoanatomy examination is must before practical conduct of the block. We always give support to the probe hand and also support to the needle hand. We use the sterile technique. We confirm orientation of the needle with ultrasound probe before looking for the sonoanatomy. We use in-plane technique, but out-of-plane can be used. Color Doppler can be used to avoid blood vessels. We open interfacial plane with hydrodissection under direct vision and then inject the solution between the plane so it can visibly bath the nerve. Optimal volume is 5 to 10 ml. We inject local anesthetic in small increments, encircle the nerve like donut. Don't move the needle until full needle is visible with bevel cut. We avoid intraneural injection by if we feel pain on injection, we should stop. If the patient cries on injection, it is intraneural, so we should stop and retrieve the needle back. If the injection pressure in the tubing is more than 15 psi, we should stop. And in a direct vision, when you see the nerves are directly visible under ultrasound, so this is again a technique to avoid intraneural injection. Use of interfacial plane. And fifth is the use of electric nerve stimulator with lowest current of 0.1 amperes. This way, if the needle is intraneural, we will find the twitch. Because at the place we are blocking, it also supplies the muscles. Thank you.